Hi guys, Misha here. Let's talk about liver failure, cirrhosis, and cholestatic syndrome. So first of all, so this is going to be the content. Basically, let's start with liver failure. Now, basically, liver failure is the worst consequence of liver injury, either acute or chronic. And in this case, obviously, we know that the liver plays many roles, and all of those roles can basically deteriorate in this case. And we can have obviously a lot of side effects and a lot of, we can say, symptoms that can appear due to liver failure. Now, when do we classify liver for it to be actually failed? How much of it has to be damaged? Like 80 to 90% of the parenchyma must be destroyed in this case. Now, we can have acute liver failure, chronic liver failure, and acute on chronic liver failure, right? So, initially, when you talk about acute liver failure, first of all, remember that it occurs within 6 months. In this case, we can see that there is massive hepatocyte necrosis, we can see coagulopathies, and we can also see encephalopathies in the case that we talk about acute liver failure. And that's how we can actually classify them into hyperacute, acute, and subacute, depending on the time frame that it takes to actually develop the encephalopathy. So in this case, it can be like 1 week till encephalopathy. It can be 1 to 3 weeks till encephalopathy in the case of acute. And in the case of subacute, we would say it take around 3 to 26 weeks till encephalopathy. In the case of hyperacute, I think I forgot to mention, is like 1 week till encephalopathy. Okay. And normally we would see this in the case of paracetamol. Next, we can talk about chronic liver failure. Chronic liver failure is actually progressive deterioration of the liver function over the course of many years. So it's more than 6 months in this case, and it occurs due to the progressive hepatocyte destruction. And always associate cirrhosis with chronic liver failure, not with acute. Next, and another thing that we can mention about in the case of chronic liver failure is that we have the huge, we can say, cirrhosis, classification, which actually classifies the prognosis. So we have A, B, and C, which basically allows us to understand if a patient requires, for example, transplantation, or what kind of treatment should be given to them. And in this case, A is like well compensated, B is partially compensated, and C is decompensated. Okay. Now comes the major thing. So first of all, let's talk about etiology. 1/3 of the cases in this case are idiopathic. In the case of acute liver failure, so etiology is for acute liver failure. We can talk about hepatotoxicity due to paracetamol 50% of the time. It can be drug induced, such as antibiotics, alcohol, or even mushroom poisoning. Or it can be, in this case, we can also say infections such as hepatitis B virus. It can be vascular, such as Budd-Chiari syndrome, shock liver, and it can be autoimmune as well, in which we can see autoimmune hepatitis, for example. Now, the clinical presentation. So you can just use this picture or the mnemonic, which is jaundice. The major, obviously, you need to mention all of them. This is extremely important. They want to hear all of them, but majorly do remember hepatorenal syndrome, and also remember hepatopulmonary syndrome in this case, like dyspnea and urinary failure, as well as neurologic, as I have already mentioned that they have encephalopathy. And obviously coagulopathy, you know why it occurs. And yeah, so make sure you remember all of these. Ascites, we know that there is a portal hypertension, which basically leads to it. Now, when talking about the morphology, we can see that they have this severe necrosis with shrunken liver. Now, initially, remember that it swells. So initially, in the case of acute liver failure, we would see that there would be hepatomegaly. But then because of the fibrosis and because of the, we can say, basically the liver starts to shrink because of the severe necrosis that develops. Basically, we have the shrunken liver. It becomes soft, congested, and but do remember that a scar would only develop in the case that there is chronic or a persistent injury. So in the case of acute, you wouldn't see scar. In the case of acute, you would see necrosis. And then we have like we may or may not have steatosis. Prognosis in this case is normally poor. 80% mortality is seen. However, these patients can survive if we give them, for example, transplantation. Now let's move on to liver cirrhosis. So I've already mentioned about chronic liver failure, right? And we said that we always associate cirrhosis with chronic liver failure because chronic liver failure can actually lead to irreversible damage, which leads to cirrhosis. So it takes more than 6 months to actually develop this. Etiologies can be alcoholic liver disease, which initially shows micronodular morphology and then starts to show macronodular morphology. Then we have non-alcoholic fatty liver disease, which can be due to, for example, patients who have diabetes mellitus, who have hyperlipidemia and obesity. Then hepatitis B virus, hepatitis C virus, normally we see macronodular morphology, and we have metabolic diseases such as hemochromatosis, Wilson's disease, for example. Then we have biliary diseases such as biliary cirrhosis or sclerosing cholangitis. Now let's move on to cirrhosis. Now, cirrhosis is basically a diffuse change in the liver architecture, right? So the most important thing that you need to mention over here is firm regenerative nodules. Okay, we have these firm regenerative nodules which are actually surrounded by a fibrotic septa, which is separating the nodules. Okay, we can see the nodules are basically being separated in this case with a fibrotic septum. Now, again, this only occurs in chronic inflammation. So, in the morphology, think about it. What would you see? You would say that the liver would appear bumpy, it would appear nodular, and the nodules are extremely firm, and they can be of different color. Like they can be yellow, they can be due to fat, they can be red in the case that we talk about hemochromatosis, or they can be green when talking about cholestasis. So I mentioned that they can be like macronodular or they can be macronodular. Now, micronodular are less than 3 millimeters in size and mostly occur due to portal cirrhosis or due to biliary cirrhosis, right? Or, for example, from alcoholism. In the case of macronodular, these are basically more than 3 millimeters in size and can occur due to viral. They can mostly, very easily can be confused with cancer. But how can we differentiate? Because cancer is pale, okay, and these nodules wouldn't be pale. And they can be also like mixed, like they can have a mixed etiology. They can be viral or autoimmune, for example. Now, microscopy, they no don't ask, but you already mentioned that the fibrotic bands with the, we can say, firm regenerative nodules is microscopy, but this is what they want to hear from you. But apart from that, you can, if you want to, you can also mention that there are hyperplastic nodules separated by fibrous bands. Again, the same thing. You can mention fibrosis that can be portal central, or can be central central. Most commonly, it is central central. So this is what it looks like. So porto central fibrosis from the portal to the central part of the we can say portal triad, for example. And then we have, for example, the central, we have the bridging fibrosis, for example. So these are basically the different types of fibrosis that occur, which eventually lead to the cirrhosis, right? So eventually it leads to what it looks like, the macronodular nodules, or we can say in the microscopy, this is what we're able to see in the case of cirrhosis. So the fibrosis that we see can be all of these three different types. We can have bile duct proliferation. We can see active versus inactive cirrhosis that can be present, like for example during the disease or after the disease. Clinical manifestations in this case can be that they may be asymptomatic. So these patients can be asymptomatic. They may have anorexia, weight loss, and like liver failure symptoms, right? Okay. So this is basically something that we can see. So let's talk about why this fibrosis basically occur, or how does the fiber dispose, in the liver. So there, for example, injured cells, and they are followed by some kind of inflammatory cells such as cytokines like TGF beta, and we have stellate cells in the spaces of Disse, right? Which reacts to the cytokines by so what happens is that, very important to remember, is that the stellate cells will actually transform into myofibroblasts. Okay, and these myofibroblasts will actually produce fiber and contract. Okay, so they basically deposit or produce the fiber and they start to contract, which leads to the liver becoming fibrosed, hardened, nodular, and shrunken, right? So this is what we're able to see because of those stellate cells which are present in the space of Disse, which are converting into myofibroblasts. Okay, so Great. So next we can talk about symptoms. So I said asymptomatic. There can be extensive scarring, which can lead to jaundice, ascites, hepatic encephalopathy, even bruising because of coagulopathies. So do remember that there's some kind of symptoms of cirrhosis, but complications are extremely important. So there are a lot of complications, and I'm just going to mention them. Some of the more important ones would be obviously portal hypertension, ascites, would be, for example, esophageal varices, for example, and esophageal varices can actually lead to death because they can burst and the person can basically have extreme amount of bleeding. So this can also be another problem. So remember that. And obviously hepatocellular carcinoma, hepatic encephalopathy. So let's explain all of these. Now, first of all, easy. We have liver insufficiency, liver failure. That's complication. Second one, decreased protein synthesis, hypoalbuminemia. What will it lead to? Edema. Okay. Next, we have portal hypertension leading to ascites, splenomegaly, caput medusa. We have esophageal varices. It can be prehepatic, it can be intrahepatic or posthepatic. So let's talk about prehepatic portal hypertension. The portal due to portal vein thrombosis or stenosis. Now, intrahepatic cirrhosis, right? We have it can be pre-sinusoidal, for example, thrombosis of the portal vein branches, or it can be sinusoidal, in which we can see perisinusoidal fibrosis, which compresses the sinusoids and resistance pressure increases, or we can have post-sinusoidal, in which we can see hepatic vein thrombosis, and that is basically Budd-Chiari syndrome, right? Then we have the post-hepatic, in which we have right hepatic failure. From the right heart failure. So we have post-hepatic due to the right heart failure or due to constrictive, we can say pericarditis. Next, we can talk about ascites. So what do we see in ascites? Obviously, we can see that there is fluid accumulating within the abdomen. So there is excess serous fluid in the peritoneal cavity. So it is only symptomatic when it is more than 500 ml. It can be caused due to portal hypertension, hypoalbuminemia, secondary hyperaldosteronism, right? So the liver basically can't metabolize it or reduce it. So the renal, we can say, blood flow and the renin angiotensin aldosterone system is basically making it worse, leading to peritonitis and hydrothorax, right? Then we have hepatorenal syndrome. So it is an intense renal vasoconstriction due to the liver cirrhosis, which induce reversible renal failure. Okay, and oliguria, we can see high BUN to keratin levels in this case. And then we can talk about decreased detoxification or metabolism. You know this, obviously, the liver has a major role in detoxification. We studied this in the in previous years. Then we have we can say hyperestrogenism in males. So more amount of estrogen can be present in them, and we can see because of the metabolism which is present within the liver is basically deteriorated. So they can have gynecomastia, spider angiomas, and they can also have these kind of basically arteriolar dilations, and Palmer erythema and testicular atrophy can be present. We can have, for example, hepatic encephalopathies, which I've previously mentioned, like tiredness. They can become very violent. They have dementia, for example, even coma due to the high NH3, and we know NH3 is so toxic, right? So we have jaundice, for example, and normally the liver converts NH3 into NH4, and then it is released within the urine, right? So then we have jaundice, which decreases conjugation of bilirubin. So we have unconjugated bilirubin increases, lipid malabsorption is present, and then we have, for example, hepatocellular carcinoma. So there are a lot that are present, but it's very logical, so it's easy to remember. Now, if they, for example, ask you, okay, what are the hallmarks, right? So the three basic hallmarks. First, we can see that the death of hepatocytes. Second, the extracellular matrix deposition of the collagen 1 and 2 in the space of Disse. And then we have 3, which is vascular reorganization can be seen. So these are basically the 3 hallmarks of cirrhosis. Now, if we talk about how would you diagnose it? So easy, we can use blood panels such as ALT, AST, bilirubin, platelets, even albumin. We can check low albumin levels, for example, and we can do liver biopsy because, as I said, that in some cases we're not able to actually differentiate between cancer and because of the nodules, like macronodules, especially. And treatment, we can use liver transplant or basically stop liver damage due to or find the reason that it is occurring and basically target that, right? Furthermore, the next part of the question basically asks about cholestatic syndrome. In cholestatic syndrome, what they really want you to mention is about cholestasis. And cholestasis has its own question as well, but we can mention it over here briefly. Now, in this case, we would see that there's impaired production, secretion, or outflow of bile, which can be either non-obstructive, basically hepatocellular. So there's some kind of either production deficit or secretion deficit into the canaliculi. So if there's inability to conjugate, for example, it is called Crigler-Najjar syndrome, or inability to deliver would be Dubin-Johnson syndrome. It can be due to oral contraceptives, right? And we can have obstructive. Obstructive is that something is basically stopping the flow. In obstructive, we can have either intrahepatic or extrahepatic. Intrahepatic, we can talk about hepatolithiasis, for example. In this case, the ducts are basically dilated, inflamed, or fibrotic. And extrahepatic, which is more common and due to, for example, tumors or some kind of stones, for example, is already mentioned here. But the most important thing is that, the accumulation of bile in the liver parenchyma and its backflow and spillage into the blood. So in all of the above cases, what kind of, you can say, bilirubin would you see? Would you see conjugated or unconjugated? And that is one of the questions that they can ask you. So the type of bilirubin that you would see that spills into the blood would be conjugated bilirubin. Okay. So in these cases, they would get conjugated, but then they would get conjugated. However, they cannot be released, or there's some kind of blockage, obstruction, non-obstruction, whatever reason, right? Now, the presentation of the patient would be jaundice, indigestion, colic pain, malabsorption. So they can have deficiency of ADEK, right? And in the case of labs, we can say ALP elevations, for example, and complications will be that they can, because of the obstruction, they may develop cholangitis, and if it is not reversed, it can lead to biliary cirrhosis. So yeah, that's basically it. If in this question they may ask you about like jaundice, there can be prehepatic, hepatic, posthepatic. So you can read about that, but that will also come in other questions. So make sure you can study that and also apply it into this question as well, because we are talking about jaundice here as well. So that's basically it from me. Thank you so much, and all the best.